I'd like to introduce my next speaker, Anupam Goel, Chief Health Information Officer at United Healthcare.
Thanks, guys. I'm a general internist by training, so no neuroscience for me. We'll talk a little bit about using technology to do work that isn't pharmaceutical-based. We didn't prepare our talks, but this is how it's working out. So for definitions perspective, let's start with disability-adjusted life years. I think that's an important metric. It tries to amalgamate life and disability into one idea. And so the idea is that DALYs equal years of life lost plus years of life lost due to disability. It's an interesting metric. It assumes that people should be healthy till 75 and we don't care after the age of 75. We can argue about the details, but it's one way to try to amalgamate these two different concepts. So if I look at, this came out of a publication about a year ago from Lancet that looked at DALYs from top causes in men and women in high income countries. So I put that out for you, and I'm not trying to get you to read all the stuff at the bottom, but the idea is that heart disease comes on at late life. There's also this, the light blue is cancer, and then there's some neurological component as well, that's the darker blue. And so they have a normal pattern, and you might expect heart disease and cancer are a major cause of DALYs for both men and women in high income areas. Okay? So now, if I go back and say, tell me more about how many DALYs by category in the United States. And so this is a different group out of the University of Washington that said we can provide some information about DALYs. And as you can see, the top two by far are cardiovascular and neoplasms. And then there's this long tail that talks about other types of causes. And so we don't talk a lot about back pain, but it's a real problem in terms of lost life. Neck pain is interesting. And then mental and neurologic conditions are shortly following, with substance abuse after that. If I get out of the disease categorization and look at symptoms, what are risk factors for these things? We can look at this a little differently. This is that same paper. Deep in the appendix, they do some work to carve out where do these DALYs come from? How do we come up with these loss of life, however you want to define it? And what you'll see is the shift in behavior started back in 2007. The number one cause of DALYs was tobacco. Fast forward 10 years, the number one cause is now high body mass index. And so if you're a fat researcher, you love this. If you're a tobacco researcher, it's not so exciting. But it gives you a sense of what's going on. I will say there's been a lot of attention around where else we might make a difference besides obesity and tobacco, but those two make up an overwhelming majority of risk factors that contribute to loss of DALYs or gain in DALYs. This is the piece that probably has a lot of attention, at least in the popular press, that we in America, this is out of the CDC, have flattened our life expectancy. And so whenever we look at costs and value for healthcare, we get crushed in America. We spend a lot of money, and I mean a lot of money on healthcare. And for the first time ever that we've been measuring this stuff, our life expectancy has flattened. And so there's lots of questions about this. How can this be? We spend so much money. What are we doing? And so if you look a little deeper, here's another example in this decade change, 2007 to 2017, looking at major causes of death. And what you'll see is most of the things are going down, right? So heart disease is going down, cancer is about flat. CLRD is respiratory lung disease. The one that's going up is actually unintentional injuries, and that includes drug overdoses. And so if you look deeper on that group for those 15 years, or so kids who are 15 years or older, there's this tremendous spike in drug use. And so I think any of you who've read the paper at least once recognize that this is really a challenge. And it is a spike over the last 5 or 6 years, just a spike in death. What are we doing? What causes this to occur? If I go back to that Lancet article, I just show you this big graph to show you that blue is good and orange is bad. And what at the top shows is this high-income countries. I'm going to pick on 3, Canada, Greenland, and the United States. And what you'll see is for the United States, drugs are a major cause of DALYs for men and women. For men, it's the number 2 cause behind BMI. For women, it's number 4 behind a couple other things. And it's so powerful that it now drops DALYs as the top 5 cause for females, which I thought was really disturbing, that we can't seem to get a handle on drugs, that we have prescription drug use, illicit drug use, it's all over. We're really struggling with this. What's really tough about this, it's not just the person who has the addiction. It's actually family members as well. This came out of the Gallup poll last month, and they surveyed people and said, how do you feel about this, and how does it affect you? And people said, look, drinking affects us, drugs affect us, both affect us, and they make a difference in family relationships and our quality of life. So it is really an epidemic that doesn't get the same headlines as heart disease and cancer, but is, if nothing else, a rising risk. And so I think a lot of us have been saying, can we look for a drug? Can we look for a behavior? Can we do something to make a difference? And so this woman, she's a PhD, Judith Kreisel, she actually was an addict herself, had lots of drugs and published this book earlier this year. And what I found really interesting was she said, even with my PhD and the research I've done on neuroscience, I don't think there's a drug that will solve this problem. The reason that I quit using drugs and the reason that I think when I see patients who are able to quit, it's because of relationships, that I connect with someone and I feel a need to make a change. And I think that's something that we in modern medicine don't appreciate enough, is respecting relationships and nurturing them as ways to heal these challenges that we haven't been able to heal from surgery or medications. This is a recent op-ed out of the New York Times, this idea that opioids don't pick on poor people or black people or purple people, they pick on everybody. And so I just want to read this to you. This came out of this writer who had a child overdose on prescription drugs. My view is that Americans can band together to go deeper into this crisis, right to the core issue, how we treat pain. Pain is the body's reaction to injury, chronic problems, and disease. Everyone is susceptible to pain of some kind. It's the unifying human experience. And so this question about what do we do for pain, I think has some question around where we're going in terms of healthcare and digital health, because I think that's an opportunity for us to think differently. And so at United, we're always looking for technology to help bend the healthcare cost curve or increase value in a way that we can scale and work outside of our traditional healthcare system. And I think this one is one I want to spend a little more time thinking about. So treatments for addiction include detox if necessary. There's a bunch of medications for different drug classes except stimulants. If you're addicted to cocaine, there are really no good drugs for you. And then a whole list of counseling techniques. And so CBT gets a lot of press, but there's also motivational interviewing and then a slew of other things that seem to have some efficacy in treating the addiction. This comes out of the Center for Addiction or Center on Addiction. It's a group that's based in New York. They're a nonprofit with some government funding and some private funding. And what you'll see here is they focus a lot about what are things you can do from a parent's perspective to help reduce drug use. What you'll see here is there's no drugs on here. There's also no digital interventions. It's the idea of connecting with your children in a different way. The group also spent some time, they published this article a few years ago, around food addiction, which I think is interesting. This idea that I don't think everyone who has a challenge with food is addicted to it, but there is some element of how we think about food that makes it different for us. And so if I shift out of drug use and shift into food, what you'll see is we have this similar trend in things going south or worse for us. Women and men are getting more obese in America over time. And that leads to an increase in diabetes prevalence. So you can look at the prevalence in 2007 and onwards, and you'll see the shift that's going up, and that's clearly a function of how we're feeding ourselves. This is a meta-analysis looking at long-term weight change and using models of efficacy. And what they found was the strongest metrics that lead to predictors or mediators of long-term weight control seem to be the autonomous motivation for physical activity. Control motivation has some effect, but really self-regulation for skill use makes a difference. So this idea of owning your skills or having efficacy around weight loss or physical activity makes a difference. So I've got this whole constellation of stuff I'm throwing at you, right? Mental illness, medication adherence, pain management, addictive behaviors, and forming healthy behaviors. And I think all of these are related and can be affected by thinking about digital health. So just to put one more twist into this, it's not like these things are in isolation. And here's a recent trial that was done, a recent analysis that was done about 3 months ago that said, let's look at people who have medication-treated depression and anxiety associated with these pretty common conditions, cancer, cardiovascular disease, diabetes, and osteoarthritis. Looked at a bunch of folks who didn't have any of these conditions, and then let's follow them for 8 years and see what makes a difference. And so again, at the top, it's depression, at the bottom is anxiety, and what you'll see is the curve that's in yellow mustard is really osteoarthritis. Pretty common problem, but it has a high collinearity with depression and anxiety. There's a whole slew of other conditions that are there, and it's controlled for a bunch of variables. And what we want to point out is something about this pain factor is leading to this perception of depression and anxiety. So there's a connection between the pain that's poorly controlled that leads to some sort of mental health connection. So how can we do a better job of that? Can online interventions make a difference? And so I will tell you, to cut to the punchline, it's all over the map. And here's a slew of studies that have been shown that where online interventions make a difference, ranging from depression to substance abuse to alcohol and illicit drugs. One Cochrane review published earlier this year shows that there may be some effect from mobile text messaging and app-based messaging to make a difference in smokers, but we can't tell if it's not as effective as bupropion or other drugs. And then there's equally an interesting list of medication or interventions that don't work. So we have this kind of noise in the data that says digital interventions may or may not work. What do we do next? And so I think we may have thought about this incompletely. And so I'm going to suggest that thinking about health should be more than just responding to a particular intervention. Can we think about global health, and people bigger, more intelligent than I have thought about this, the idea of physical, mental, and social health all interacting to make a difference in self-reported health for overall global perception. When we think about behavior change, I think the folks who've gotten the most attention are Prochka and these stages of change. We talk about, oh, you're pre-contemplative or contemplative, and I think it's been a complete waste of time. We've spent millions of dollars to help people quit smoking, and we've done a pretty bad job of it. So here's an alternative idea. This idea called the self-determination theory came out of a group. The group is Dacey and Ryan. They published it, I think, in the late 90s. And they said, look, there's more to this than just your stage of change. Can we use these three ideas? How competent do you feel? Do you have autonomy over what you think you're doing? And do you have a relationship with others that connect to what you want to get done? And then there's a second piece around, is the motivation internal or external? That's really the autonomy piece. The competence has a connection to Mihai Csikszentmihalyi, who does work around flow theory. This idea that if you're working in the zone, which not so hard it's impossible, but hard enough where you're challenged, you might make a difference and improve your skills over time. And then relatedness is the idea of connecting socially, which I think has value, but we really haven't done a great job in facilitating that using social techniques. This is a deeper drill down into the self-determination theory. We think about, on the far left is this idea that someone is telling me what to do. You can think about any of us who are parents. This is what we do all the time. You do this because I said so. If you go further to the right, there are increasing levels of internal autonomy or self-determination, intrinsic motivation. I will play the violin because I want to get better at the violin, not because Dad told me to do so. So what we're thinking about is what interventions make a difference to move us from I told you so to doing it yourself. The corollary for adults might be, how do I get from running a race to win to running a race because it's important to me? And I think we are lacking in that research area to help move that forward. Here's one person's interpretation of self-determination theory. I just want to point out that they've tried to think about some things like choice and rationale that feed intrinsic motivation, but talk about things like internalization and developmental needs. I want to spend a little bit of time focusing on this piece, which is this idea of regulation. Can I regulate myself, and can that make a difference in things like mental health, addiction, and other things we talked about earlier? And this person actually pushed harder on choice and rationale. And so there's been some research, this was done about 5 years ago, that said, let's look at this with a series of measurements to say, can the healthcare climate and individual differences be measured, and then use that to predict perceived competence and then autonomous self-regulation, which then leads to maintained behavioral change. And I think this is really a challenge for us in healthcare, that many of these trials that we've seen published have been about 6 months long or maybe 6 weeks long, and we're not able to see long-term behavior change. And part of it reflects the reality that people change a lot over time, but we're not able to sustain behavior after a short period of observation. So Dacey actually wrote a follow-up paper in 2002, I think, that's what this, what follow the link, that said, how might I theorize pushing people more to internal control or internal regulation? And this was the group actually together said, we think these three things are necessary. You've got to give a why. And so those of you who listen to Simon Sinek, he's made an entire industry about the why. Provide a meaningful rationale. Acknowledge that person's feelings. It's really hard for you, however you want to do it. And then finally, conveying choice. I mentioned this earlier in the slide deck. This idea that you have a choice. You can choose to do this or you can choose not to do this. I'm not making you. You can decide what you want to do. And the insight or the pearl that they suggested was that when social context supports self-determination, that is, the individual makes the choice, they tend to integrate, or in the parlance that they're using. For us, it would be they tend to be more internally regulated rather than externally regulated. Other folks have tried to expand on this, and they've said, if you do these things, it makes a difference. Can you provide self-awareness and self-knowledge? Can you do some goal setting and problem solving? All of these things that may make a difference to help people feel like they've got more autonomy or control over their condition. I think it's a little deeper than that. I think it's, when I think about behavior change for myself and patients who've made a difference in their own lives, it's they've defined themselves differently. This idea of identity allows you to do different things. Mainly it says, if I am X, let's say I don't run, but if I'm a marathon runner, I have goals. And maybe those goals are running faster. To meet those goals, I need to have new behaviors. And those new behaviors then reinforce or take away from my identity. I'll pick on myself. I want to be a thought leader at United Healthcare, and so that means I have to write. And so I was having a really hard time writing every day. And so I had to come to grips with the fact that I'm making choices that say writing isn't important to me. Once I said, I want to be a thought leader, then I said, okay, that means writing every day. That means reading every day. And so then I had goals with behaviors that shifted what I had 6 months ago. And so I would suggest to all of you that this paradigm may be helpful as we design digital interventions to address the challenges I've outlined earlier. And we haven't really thought about that when we think about digital interventions. This was out of the Journal of Internet Research that said you can think about this entire continuum of prevention, diagnosis, decision, treatment, and follow-up with technology kind of supporting all the way through. And I will tell you that I think there are opportunities in these spaces specifically. I know lots of people talk about bots taking over healthcare and taking doctors away, and that may happen in our lifetimes. What I think is a more palatable change is focusing on education and health awareness and allowing the clinician, it doesn't have to be a doc, but allowing the clinician to make a diagnosis. There's a high level of trust and uncertainty from the member's perspective or patient's perspective. Allow that to continue to occur face-to-face. And then once a diagnosis is made, use technology to support that decision long-term. So I have a problem, whatever that problem is, you have a drug addiction. Can I use technology now to help support the drug addiction without a doctor visit face-to-face? And we think that's a more realistic way to move forward than trying to do all the pieces at once, which I think a lot of folks have suggested, at least in the literature. So I just want to highlight this one idea that tries to step away from the doctor being the mediator of this work. And this was a publication earlier this year out of Zimbabwe. And these folks, what they did was they looked at a group of lay health workers. And I mean, they just got a couple of weeks of training on how to deal with, how to teach others how to do problem-solving therapy. And they were out to help people in Zimbabwe. And they had these little benches that they went out there and they talked to people. And they had some sessions with them, and then they were offered a chance to do some texting afterwards if they wanted to. If you look at the outcomes, and I just have a bunch of measures here for those of you who really care. PHQ-9 is important, GAD-7, there's a whole bunch of others. But all of them improved. And it was pretty impressive. It was so impressive that the city of New York City themselves, have taken the same study and now using orange benches in their own place to help make a difference in mental health in their communities in New York. So this idea is it doesn't have to be docs or even people with licenses. That giving people skills to do this outreach for relatedness may be more effective than coming up with cooler tools or technology to make this work. And so to follow that thread a little further, I think it's interesting to think about when we look at the things that get attention in the popular press or even in the scientific press, people talk about a fully automated solution, or they talk about professionals working without technology support, and then sometimes they mention telemedicine. And they're shown as these kind of poles that that's what we have to do. And I think it's a little more nuanced than that. And if we think about this continuum, that you may start without technology support, and then you might have face-to-face support for technology, then you might use telemedicine, and then you might have telemedicine linked with lay workers, and then you might have remote support, and then fully automated. This series of steps helps you get a better sense of where the drop-offs are in efficacy and where you might intervene differently. And that's what we're thinking about at United is how can we intervene in ways that support the existing healthcare system to make a difference long-term where people want to be. Okay, so we're being home. 2 slides. So what are the things I want you to remember when we get out of here? One is health information technology can address multiple drivers of morbidity and mortality using psychological techniques. What I'm trying to really focus on is not drugs. Can we do something besides drugs? Because we don't want to get in the business of prescribing remotely. That has a whole set of challenges that I don't want to discuss. Health information technology has mixed success to date moving patient-oriented outcomes. So we can do some work to say, yes, they click the button more, but are we making a difference in depression or anxiety or healthcare spend? Not so sure. If we can shift identity and think about interventions based on self-determination theory with cognitive behavioral therapy or other therapies, could that help increase health information technology intervention effectiveness? Maybe. It requires us thinking about interventions differently. There was a publication yesterday at the New England Journal that looked at Apple Watches. And what they found was, the first thing was, out of the 400,000 people they recruited, 80% of them were under the age of 40, which was kind of a waste. So forget those. So the folks who were over 40, they found that the people who had an irregular heartbeat merited an evaluation for atrial fibrillation, and they mailed them a small patch to check they had atrial fibrillation. And what they found was 80% of the folks did not put the patch on. So the device can identify a problem, but it can't help the follow-up to make verifying the diagnosis. And I think one of the challenges with health IT for all of us is you can identify lots of data points, but if you can't lead to behavior change long-term beyond that initial wow factor, we're not getting very far. Okay, and then health IT interventions. We should think about things across the spectrum for each symptom of the complex or disease. So not only do we think about early case disease, but potentially advanced disease, and maybe recovery after an acute episode. When possible, think about interventions within a planned healthcare delivery system. I think everyone wants to Uberize, or I guess now the term is TikTok, a solution. And I would suggest that any of those solutions in healthcare have not succeeded because most patients feel like they should be connected to some doctor to make it last long term. I'm not sure how long it's going to last with millennials, but today that's where we're at. HIT can provide information, it can deliver feedback, and do this work of connectivity, including with healthcare workers. And so I think the nice thing about this idea of using technology, and I think other speakers have talked about it today, is that HIT can do some work around measuring effectiveness that's different than the technology you might use to deliver an intervention. And the nice part is most health information technology can feed back to clinicians in case of danger or when things are necessary. And then finally, thinking about new functions as pilot results inform the next steps, what to do next. And I think all of us are kind of going, let's hit the grand slam, and we keep striking out. So let's try for more singles to say, can we learn from step 1 to get to step 2? And I think we're not doing enough of that, or those steps aren't getting publicized in enough detail. Stop there. I'll repeat your question if that helps.
I'm interested in your take on reset and reset out. So the first prescription digital therapeutics that were kind of approved by FDA for treatment of substance abuse disorders. I don't know if you have your thoughts on that as a health insurer, and be very interesting.
So what was the intervention?
So reset and reset out, there are two digital therapeutics.
I don't know enough about that.
Oh, that's interesting.
No, they have it on my radar screen, but I'm not the mental health person, so that
Okay.
they may know about it. So sorry.
Okay.
I will say that, and I'll speak not about that specifically, but in general, the knock on digital applications has been long-term adherence.
Yep.
That people jump on the first month, the second month less so, the third month less so. And this idea of how to keep people engaged is really the challenge.
Yep.
There was a different study. I won't talk about that intervention specifically, but I'll talk about physical activity. People have been talking about gamification. Can we make a difference with that? And so the idea of, can I get my friends or my peers to help me think about walking more steps? That's gotten a lot of attention, and every employer wants to do it because they want the people to be more active. And there was a publication out of JAMA 3 months ago that said, let's randomize people, and it was a large consulting group, so younger people in general, but across the country, where they said, let's do gamification, let's do social support. It says, let's pick a loved one to reach out to you and say, hey, walking is important, and let's do usual care. And so what they found was, after 3 weeks, everybody walked a lot. And then the intervention went away, and the people who had no intervention stopped walking, or they went back to their baseline. And the public press actually said, look, gamification works, here it goes. It showed an increase and went down. And I think at a deeper analysis, my interpretation was, gamification works, yes, you can set that up, but so did relationships. That a loved one reaching out to you saying, hey, walking is important, I want you to be healthier, was as effective as setting up a complicated contraption for gamification. But both interventions stopped the effectiveness when the intervention ended. So I think gamification in general is interesting, but at some point the video game ends, and what are we doing next? And I think that's an ongoing journey for us. So whatever Facebook is doing, we got to do more of that in healthcare.
Thank you.